Hey, welcome back to Not So Complicated, and it's day 2 for clinical case discussion. Let's begin. So, a 28-year-old female presents to the emergency department with a 3-day history of worsening shortness of breath and right-sided chest pain. She reports a dry cough and low-grade fever, 38.2 degrees Celsius, that started 5 days ago after returning from a long-haul flight. She denies trauma or recent surgery but mentions oral contraceptive use and a family history of clotting disorders. I get a sense of that question that it is probably pointing us to clotting disorders or something like coagulability or like that. Let's see. On examination, BP is 110 by 70 mmHg, which is normal, and heart rate is 115 beats per minute, which is increased. Respiratory rate 28 per minute, which is also increased. Oxygen saturation 88% in room here. It's fall, it is crashing, and temperature is 38.4 degrees Celsius. A long exam reveals decreased breath sounds and a dullness to percussion on the right lower lobe. An ECG shows sinus tachycardia with an S1Q3T3 pattern. Chest X-ray is pending. So S1Q3T3 pattern is also called McGinn-White sign. It is usually seen in pulmonary embolism. But let's see what is the most likely diagnosis. We got options in here, and pneumonia, pulmonary embolism, pneumothorax, acute respiratory distress syndrome, and pleural effusion. Let's debunk each options and analyze whether they can be or cannot be. Well, I have put the case recap in above because we need to know what was in the question. So basically a pneumonia. Let's debunk. So pneumonia, fever, cough, dyspnea. There are fever, 3 days of worsening dyspnea, and also fever of 38.2 degrees Celsius, and there is cough, sure, but dry cough and sudden post-flight onset doesn't scream infection, so it doesn't look like infection, right? And dullness in right lower lobe fits consolidation, but there are no crackles, no sputum. Oxygen 88% is too low for mild pneumonia, and OCP, oral contraceptive pills, and flight history lean elsewhere. S1Q3T3, McGinn-White sign. That's not box, that's clot vibes, right? So S1Q3T3, we can see in the ECG that S wave is used in lead 1 and Q wave in lead 3, and there is an inverted T wave in lead 3. So basically pneumonia is highly unlikely, but let's consider it too. And the second option is pulmonary embolism. There is dyspnea, chest pain, oxygen saturation of 88%, heart rate 115, classic pulmonary embolism after a flight. There is history of coagulation, hypercoagulability, and also the use of oral contraceptive pills, which is leaning to the Vicos triad, and also S1Q3T3 on ECG. It is rare, only 10 to 15% of pulmonary embolism, so McGinn-White sign. And also dullness or decreased sounds. It may be due to segmental collapse from embolus. This might be the killer. Let's hold it. Maybe this is. I lean towards it. And the third option is pneumothorax. Let's debunk that as well. There is chest pain and dyspnea, yeah, but no sudden onset. There is no history of trauma, no hyporesonance. In fact, there is right lower lobe dullness. So pneumothorax can be directly ruled out in it, eliminated out. And post-flight is not pneumo's game, and oxygen is 88% fits, but S1Q3T3 is a cardiac strain. OCP or clot history doesn't play in here, unlikely. The fourth option is acute respiratory distress syndrome. ARDS needs a trigger, obviously. It may be sepsis or trauma or aspiration, and not a flight. And OCP, yeah, oxygen is 88%, with hypoxia, but there are no bilateral crackles and no diffuse chest X-ray haze. Even if it's pending, I don't expect to be there a diffuse chest X-ray haze. The onset is too focal, which is right-sided. S1Q3T3 points vascular, not alveolar flood, so it is also unlikely. Option fifth is pleural effusion. There is dullness and decreased sounds, obviously, and if it is a effusion spare, because there is right lower lobe dullness and decreased sounds in auscultation. And dyspnea is too acute, pain is too sharp and fever is off for simple fluid because it is very low grade fever, and no CHF, no malignancy hints. Post flight OCP clotting history doesn't fit transitate or exudate slow build, right? S1Q3T3, there is a far relation of pleural effusion with S1Q3T3, so it is also unlikely. Given all options getting debunked, we might lean towards pulmonary embolism, and yes, the diagnosis is pulmonary embolism. So what is a pulmonary embolism? Pulmonary embolism is a clot, usually due to deep vein thrombosis, jams the pulmonary artery and blocks perfusion. What are the types? The types of pulmonary embolism are acute or chronic, and also massive or submassive. Massive occurs in shock and submassive occurs in right ventricular strain, like here. And also in this case, 3 days of worsening submassive pulmonary embolism, right ventricular stress, which is shown by McGinn-White sign, and there is post-flight DVT origin. This is the case. And what can be the causes? The causes can be Virchow's triad. You can see in the photo inside. Virchow's triad here is stasis, which is due to flight, and hypercoagulability due to family history and OCP use, and endothelial injury, which is smoking risk, and it causes clot to lodge in right pulmonary artery. The photo inside shows abnormal basal wall, abnormal blood flow, and abnormal blood constituents are the Virchow's triad. And the reason for abnormal basal wall are endothelial dysfunction, disturbances, damage, or contact pathway activation, tissue factor release, and abnormal blood flow due to venous obstruction or stasis, atrial fibrillation, aortic stenosis, mechanical waves, and abnormal blood constituents due to abnormalities in thrombin generation, platelets, or coagulation and fibrinolytic pathways. Other cellular components or microparticles can cause, and all three of these can cause hypercoagulability, also a clot, which is also called the Virchow's triad. And the result of this is BQ mismatch, which is also the ventilation perfusion mismatch due to dyspnea. Oxygen sat is 88%, right ventricular strain, which is seen by tachycardia, and heart rate was 115 in the case, and S1Q3T3 obviously. Infarct, if big, leads to pain and fever, and at the time 3 days, DVT brewed and plain, embolized, and now killing her lung. And also pulmonary embolism is associated with Wells score, and the Wells score is very high, almost 6 plus, due to tachycardia, immobilization, P likely due to OCP or clot history. Wells score, we have discussed about Wells score in our previous case discussion, and the ECG shows S1Q3T3, deep S in lead 1 and Q in lead 3, T inversion lead 3, and it points us to the right ventricular strain, which is also 10 to 20% pulmonary embolism cases. And in imaging, we do CT pulmonary angiogram, which is gold standard for pulmonary embolism, and it shows filling defect, D-dimer if low risk, not here. And in this case, we have to do CT stat S1Q3T3 plus risk equals pulmonary embolism till ruled out, and also leg ultrasonography should be done for deep vein thrombosis next. And the management of this case can be due to in acute management, oxygen saturation should be maintained above 90%, and also heparin to dissolve the clot is given as bolus plus drip, or low molecular weight heparin to stop the clot growth. And also the alternatives could be thrombolytics, which is TPA if shock, not yet, and catheter embolectomy if massive. Long-term treatment is by administration of warfarin or DOACs, 3 to 6 months, OCP off, clot risk sky highs. And in this case, we have to do heparin right now. We have to administer heparin and CT confirm, serve her long, and ventilate her. And the prognosis in here are risks of right ventricular failure, which is S1Q3T3 hint, and also recurrent pulmonary embolism can occur due to the history of family history of that, and also the constant use of OCP. So the OCP should be reduced or not taken in this risk, and also chronic thromboembolic pulmonary hypertension. and the stats are 10% mortality rate is there if the pulmonary embolism is left untreated, and less than 5% with anticoagulation, minus flight, plus OCP. Or not plus OCP means we have to minus anticoagulation, or we have to remove the flight, we have to stop the flight and OCPs for quite a time to reduce the risk of developing recurrent pulmonary embolism. So that is it for our second case discussion, and subscribe for next case discussion, which will be tomorrow. Or we are doing a day-to-day clinical case discussion, so subscribe. Thank you.